Hello, fellow health enthusiasts. Welcome back. Today our topic is foreign body inhalation. But before we get started, don't forget to subscribe to our channel and hit that notification bell so you never miss out on our latest medical insights. Now, let's get started. A multitude of defensive systems exist in the human body to keep foreign items out of the airway. These include the physical actions of the arytenoid and epiglottic cartilages, cough reflex, and the intense spasm of the true and false vocal cords. All these systems are effective, but still, foreign bodies often become lodged in children's airways. The vast majority of foreign body inhalation events occur in children under 4 years. Older children with developmental impairment may continue to be at risk. Button batteries are more commonly ingested than inhaled, but recognition and management are critical. Most inhaled foreign bodies are located in the bronchi rather than the larynx or trachea. Children are more prone to aspirate foreign material. As they lack molar teeth, so find it more difficult to chew their food properly, which results in larger pieces that they must swallow. They also tend to laugh, talk, and run while they are chewing. The most common entities aspirated are small food items such as nuts, raisins, seeds, coins, popcorn, balloons, pieces of toys, improperly chewed pieces of meat, and small, smooth items such as grapes, hot dogs, and sausages. Small items that are round, smooth, or both, for example grapes, hot dogs, sausages, balloons, are more likely to cause tracheal obstruction and asphyxiation. Dried foods may cause progressive obstruction as they absorb water. Right-sided airway entries are more common. The presenting features of inhalation will vary depending upon the site of impaction, degree of blockage, and type of object. Children may present with symptoms days to weeks after inhalation. The most fatal cases involve acute aspiration that results in complete or nearly complete airway obstruction, hypoxic brain injury, or death. Foreign body in larynx or trachea can be fatal. Coughing, choking, vomiting, severe respiratory distress, stridor, cyanosis, altered mental state, drooling, and voice changes. Total obstruction will rapidly lead to unconsciousness and cardiorespiratory arrest. Can present as cardiorespiratory arrest and are impossible to ventilate. Impaction in the main bronchus. Episodes of choking, coughing, or wheezing while eating or playing, tachypnea and respiratory distress, cyanosis, persistent wheezing, persistent cough, fever, hemoptysis, dyspnea, recurrent or persistent consolidation, may be asymptomatic after an initial event before developing complications, pneumonia, abscess, bronchiectasis. Impaction lower than the main bronchus. Often asymptomatic after the initial event, or may have symptoms as for main bronchus foreign body. The examination may be normal. Keep the child in the preferred position. Work of breathing. Major findings include new abnormal airway sounds, stridor, focal wheeze, or decreased breath sounds. Sounds are inspiratory if the material is in the extrathoracic trachea. If the lesion is in the intrathoracic trachea, noises are symmetric but sound more prominent in the central airways. These sounds are a coarse wheeze. When the foreign body passes the carina, the breath sounds are usually asymmetric. Also confined, drooling and altered voice quality, asymmetrical chest movement, tracheal deviation. Check for other foreign bodies in ears, nose, and throat. If the child is stable, potential complications include atelectasis due to prolonged airway obstruction, bronchiectasis due to chronic infection, lung abscess, pneumomediastinum, and pneumothorax. Rare complications of foreign body removal. A normal respiratory examination or chest X-ray does not exclude an inhaled foreign body, as most commonly inhaled objects are radiolucent. They are frequently unwitnessed, so a high degree of suspicion is required in young children with respiratory symptoms. Chest X-ray, with or without inspiratory and expiratory films, or children who cannot cooperate with lateral decubitus views. Check for radio-opaque foreign body. Area of atelectasis. Hyperinflation distal to obstruction, causing air trapping. Mediastinal shift. Consolidation suggestive of pneumonia, pneumothorax. Pulmonary abscess and bronchiectasis are signs of a chronic impacted foreign body. Chest CT scanning may reveal the material in the airway, focal airway edema, or focal overinflation if CXR cannot detect it. If high suspicion, many forego CT scanning and proceed to bronchoscopy. RCH Guideline doesn't recommend CT. Rigid bronchoscopy is better than flexible bronchoscopy in children for manipulating foreign bodies during surgery. Although flexible bronchoscopy is better for identifying foreign bodies, if required, provide emergency resuscitation before other management. All children must be under constant close surveillance until the foreign body is removed, since any movement could result in abrupt closure of the airway. Bronchodilators and corticosteroids should not be used. Chest physical therapy with postural drainage may dislodge, leading to more harm. If the child has respiratory distress and is unable to speak or cry, complete airway obstruction is probable, so in those cases, a Heimlich maneuver may be performed. Surgically endoscopic removal, usually with a rigid bronchoscope, can be done by a physician skilled in pediatric airway procedures, ideally, anesthesiologist or ENT specialist, in the operating room. Here is the flow chart from RCH Guidelines for emergency management for foreign body inhalation. If the child can't cough it out or there is a risk of total obstruction, contact a specialist to secure the airway. If responding, do 5 chest and back thrusts. If no response, do CPR and direct laryngoscopy to find the foreign body. Remove with McGill forceps if found. If there is relief within 1 minute with adequate breathing, provide supportive care and send to theater for foreign body removal. If no spontaneous breathing, start positive pressure ventilation and send to the theater. If no relief within 1 minute or if unsuccessful removal, go for the intubation method if below vocal cords and cricothyroidotomy if above it. If it is not felt to be safe to attempt these procedures, basic resuscitation should be continued while awaiting senior assistance. Subacute management, send children with stable airways who continue to raise suspicions following history and evaluation to an ENT or respiratory team so that a bronchoscopy might be considered. Keep your level of suspicion high and your consultation threshold low. Prevention methods. Youngsters under the age of 5 are most vulnerable. Hard, rounded foods are not appropriate for small children. When serving meals to children, remind them to always sit quietly and to take one piece at a time. If the child is younger than 3, stay clear of toys with little parts. Alright, folks, that wraps up our discussion on foreign body inhalation. If you found this information helpful, please share it with friends and family. Don't forget to like this video, subscribe to our channel, and hit the notification bell so you never miss out on our latest medical insights. Stay informed, stay safe, and take care of yourselves.